This video will document the extended endonasal resection of a tuberculum cell meningioma. Patient presents with visual loss, was found to have a small tuberculum cell meningioma extending up to the anterior cerebral arteries. It extended down into the sella and forward just behind the cribriform plate. An excellent candidate for an endonasal endoscopic approach. Vascularized nasoseptal flap was harvested by ENT back to the anterior wall of the sphenoid. The sphenoid sinus was widely open after removing the posterior third of the septum. Flap was harvested from the contralateral side as well, exposing both ostium of the sphenoid sinus. The keel was removed and the floor was drilled down to ease the placement of the flaps at the end. The mucosa was completely removed from the sphenoid sinus to prevent a mucocele. All of the septations were drilled down flat, and then the opening was performed. Given the size of the tumor, quite a bit of the planum had to be removed anteriorly, as well as the tuberculum extending from medial intercavernous sinus to medial intercavernous sinus down to the very top of the sella. The floor of the sella does not need to be removed and will be helpful to wedge a piece of bone during our closure. Here we're removing the medial OCR with a kerrison on one side, and then we'll extend our planum opening with a backbiting frontal sinus kerrison. Here we're opening the dura laterally towards the other OCR, and then the dura is opened and removed with a kerrison to expose the tumor. The dura is bitten back all the way until the margin of the tumor is identified and the arachnoid can be seen. First, we dissect over the top of the tumor. This is the area where they're least likely to encounter a blood vessel attached to the tumor, and the tumor is rolled in and internally decompressed until we expose the A2 branches, which can be seen superiorly. Lucky for us, this is a relatively soft tumor that can be suctioned and internally debulked. The optic nerves are seen behind, as well as the chiasm. The medial optic canal is opened on both sides to make sure the tumor is completely removed, and angled endoscopes can be used to examine the medial canal and see the ophthalmic artery as well as the stalk below. Closure is performed with an inlay of duraform, and then using alloderm, a gasket seal, is performed with medpore wedged in to keep the alloderm in place. This is then covered with a vascularized nasoseptal flap, and this flap is further covered with adherus, flow seal, and nasopore. Post-op MRI reveals a gross total resection of the tumor.